Now we have started recording our session and I will share the slide with you. Where is that slide? Small intestine. Why it is opening like this? PowerPoint live. So can you see the slide now? Small intestine number 1.
Yes, sir.
Okay. Layout, intent, stand out. How can I move myself? My image is in the center or it is obstructing the view? Is it in the center or obstructing you? If I go here, you see only the slide or also me? I don't know.
Both. Both.
So it is obstructing the slide view or no? Let's say I go to the next slide. Can you see all the content or I have to hide myself?
Maybe it's better, doctor, to hide.
Yeah, the content
Because
only.
some of the words cannot be seen.
Yes, okay, this is okay. Because maybe I thought, yeah. Okay, concentrate on the slide only. In the small intestine 1, we discussed about the motility and secretion. Here, the small intestine described the motility, segmentation, and migrating motility complex. Segmentation. What is mean by segmentation? Segmentation is nothing but dividing it to the whole small intestine into smaller sacs or smaller areas. Smaller areas. So if you see the slide, you will be able to find out the picture. Yeah, before we go to the slide, actual description. This is how the whole small intestine is divided into smaller parts. We call it as segments. Juz, wahid juz. Okay. So one area, second area, third area, fourth area. Why it will be divided? It is divided because of contraction of the muscles, smooth muscles, contraction of the smooth muscles here, here. Okay, can you see the pointer? Yes. Here is the contraction. Second contraction is here. Third contraction is here. Fourth contraction is here. So it is dividing it into smaller segments. After some time, this contraction area will relax and the area which was previously relaxed, now it will contract. Now it will contract. This is how the the smaller segments will move the food. It will move the food from one area to other area. Also, it will mix the food. Here, just for the purpose of understanding, it is shown here yellow color, brown color, yellow color, brown color alternatively. In the next contraction phase, this half yellow, half brown is mixed, half yellow, half brown is mixed. In the third contraction, again, there will be mixing of the alternative segments. This is how it will help us to mix the food. Segmentation contraction is mainly mixing the food. Also, it will roll the chyme, food or chyme. The partially digested food is called as chyme. So it is rolling the food into the pipe or into the lumen so that it will come across all the areas of the mucosa and it will be absorbed. Okay, this is the purpose of. I will go back to the written material here. So segmentation contraction is nothing but the small oscillating. Oscillating means contraction followed by relaxation, just like a uh, pendulum of the clock, which will go from one area to other area. So contraction and relaxation is occurring in the form of rings of contraction in one segment, and then after that in the second segment. This will make the alternative segments. This will make a segments and this will allow the food to mix with the digestive juices as well as to come in touch with the luminal wall or the mucosal wall so that it will be absorbed or come in contact with the liquid there. This is called as the segmentation contraction. Rate of segmentation contraction is there. Okay, first of all, why this segmentation contraction occurs? Why? Because segmentation contraction occurs because of there are some autorhythmic cells are there within the wall. They are continuously changing their potential, going up and down. From depolarization and repolarization waves are continuously going on. So there is no resting membrane potential. By this way, we say there is no resting membrane potential. These cells will be always in a changing potential. Because of the movement of the ions, the potential will be changing. It is going from depolarization state to repolarization and coming back to the depolarization. If it is stretched, or if it is stimulated by some of the chemicals or hormones, this will reach to the threshold level and there will be action potential will generate here. Here also there will be, if they reach to the threshold potential, then action potential will be generated. This movement, which is going up and down and up and down in the electrical property of the muscles, this is known as basic electrical rhythm. This is known as basic electrical rhythm. This change in the potential of the cells of the smooth muscles of the small intestine is known as basic electrical rhythm. And because of the basic electrical rhythm, if they reach to the threshold, there will be contraction. And this contraction will be in the form of rings of contraction, which will make here, which will make it in the form of segments, divide the small intestine into segments. Because of the segmentation, there will be mixing of the food. Because of the segmentation, mixing of the food will be occurring. Now, this is initiated by the local distension. When the chyme is there, it will stretch the wall. This is a mechanical change which will be causing the threshold to reach to the threshold, or basic electrical rhythm to reach to the threshold. Also by gastrin. Gastrin is a GI hormone which is released by the secreted by the stomach cells, and then it will act on the intestinal smooth muscles. This will lead to ring of contractions. This is known as gastroileal reflex. Something released from the stomach, that is gastro, and acting on the ileum or the small intestine, it is called as gastroileal reflex. Also, it can be done by parasympathetic stimulation, whereas opposite to that, sympathetic stimulation will decrease this segmental activity. Okay. Now we have seen that why it occurs, and this will lead to the mixing of the movement. But how it will cause the movement of the food to pass from one area to another area, because there is contraction and relaxation at the same place. These are not the peristaltic wave. These are not the peristaltic wave. These are the local contraction and relaxation. These are local contraction and relaxation. They are not moving from one place to another place. So how the food will move then? We say that food will also move. This will move because the rate of contraction is different in different segments. So let's say for about in the duodenum, which is the early part of the small intestine, the rate is 12 per minute, 12 times in 1 minute, 12 times in 1 minute. Whereas in the ileum, terminal ileum, it is about 9 times per minute. So initially there is slightly faster contraction and relaxation. And in the later part, there are slow contraction and relaxation. So food will not move in this direction. Food will move from faster to slower. So it will move from duodenum to the ileum. So the function of segmentation contraction by this way is mixing the food, because it will be dividing the segment into dividing the intestine into segments. Also, it will expose the food to the mucosa, so which will help in absorption, and also it will help in propelling or moving the food forward. Moving the food forward. So these are the three uh, uh, functions of the segmentation contraction. Okay. Any difficulty in understanding the segmentation contraction? Are you listening to me?
Yes, clear, doctor.
Yes, yes, doctor.
Yeah. So segmentation contraction is dividing the small intestine into segments, pieces, which will help in mixing the food with the digestive juices. Also, it will help to move the food rolling into the inside the lumen so that it will come across or touch to the mucosa, and it will help in absorption. And also it will move forward the food from duodenum to ileum. Second activity which is found in the second type of motility which is found in the small intestine is known as migrating motility complex, MMC, or migrating motility complex. They are sweeping. They are small peristaltic wave. They are a small peristaltic or weak peristaltic wave. They are weak peristaltic wave. Whenever the term peristalsis comes, that means it will move from one area to another area. Peristalsis means moving, whereas segmentations are not moving. They are just at the local contraction. So these are the weak repetitive peristaltic wave that are starting from one point, and it will die at the very nearby. In the nearby area, it will just move for a very short distance, few centimeters only. From here it will start and it will end here. From here it will start and it will end here. From here it will start and end here. It is not the one which is you have seen in the esophagus, where it will start from the upper part and then till end of the esophageal sphincter it will come. No, it's not like that. It is moving very short distance. So that's why they are called as repetitive weak peristaltic wave, which will push the food to or push the chyme a very short distance. Then what will happen? The second wave will start. Second wave will push the food again to a short distance. Third wave will start. It will move again to a short distance. By this way, it will sweep everything from one area to other area, from one part of the small intestine to other parts of the small intestine. So they are starting at the stomach and migrate. Stomach means does not mean directly in the within the stomach, but at the end of the stomach or beginning of the duodenum, and they will be sweeping. Sweeping means cleaning. You have seen the cleaners. They take a brush and sweep the area or clean the area and then push all the dirt and the garbage to in one corner of the room or a road, something like that. So they are nothing but these more MMC are nothing but those which will push the food or chyme from one area to another area so that it will remain empty for the next meal. So they will clean everything, keep the things ready so that it will receive the next chyme or next meal. From where to where they are moving? From small intestine to the colon. From small intestine, these small peristaltic waves, they will push from duodenum to jejunum, jejunum to ileum, ileum to the cecum. So slow waves, short distance waves, moving from one area to other area and pushing the food forward. These are called as migrating motility complex or MMC. How they are generated and how they will be regulated? Through a hormone which is known as motilin. Through the hormone which is motilin, which is secreted by the small intestinal mucosal cells. Small intestinal mucosal cells. As they are cleaning the small intestine and keeping it ready for the next chyme or next meal, they are called as housekeeper contraction or housekeeper of the small intestine. Housekeeper of the small intestine. This is the terminology they gave it. To show it, we shown you the video that all these men are nothing but, let's say, 1, 2, and 3, and 4. These are nothing but the small peristaltic waves. So this will push the dirt or the garbage from one area to this area and it will die out. Then from here, the second wave will start and it will take the garbage to the sweep to the third area. Then the third will take it to the fourth area. In this way, the whole things will get clean. So this is how we are calling it as a intestinal housekeeper. Intestinal housekeeper. In hotel, when you stay in a hotel, every morning some cleaners comes and they knock the door. You ask them who are you, and they say housekeeping. So housekeeping is nothing but they are cleaners. They are cleaning. So these are called as the housekeeper of the small intestine. Video is there. You already saw that one. And then in this lecture, ileocecal sphincter was described. It is nothing but a valve or a guard at the point where small intestine ends and large intestine starts within the cecum, and how it will be helping to keep the ileocecal sphincter closed so that the colonic bacteria should not enter into the small intestine. So the function of ileocecal sphincter is to keep away the colonic bacteria from entering into the small intestine. Here I will show you in the picture. Yeah. So small intestine is going to end here and it will protrude. It will not just touch and we remain here, but it will go inside, little bit inside, so that whenever there is a outer pressure, it will close the valve. Whenever there is a chyme coming from the small intestine, it can open and throw it into the cecum like that. So there is a valvular function is there at the ileocecal sphincter. Anything else? If you want me to go faster or concentrate on the particular thing, you can stop me in between. OK, so the mucosa of the small intestine has got so many cells, so many glands, and they are secreting a juice similar to the gastric juice. Here in the intestinal juice is known as succus entericus. Succus entericus is nothing but the secretion of the small intestine, which is helpful for digestion as well as in keeping the mucus there, which will be helping it to push the food smoothly. And it is secreted by, and the here you have to remember the histology of small intestine. The small intestine is thrown into various folds. Over the folds, you will find there are villi. Over the villi, you will find cells. Over the cells, you will find the microvilli. And these microvilli will form the brush border. These microvilli will form the brush border. So enzymes are present on the brush borders, not in the lumen, not here, because it will be double here. So enzyme is not lying in the lumen, not lying here. It's not there, but it is lying on the brush border. So enzymes are on the brush borders. What it contain? It contain mainly water. It contain mucus, which will facilitate easy passage of the food or chyme. It contain mineral salts and its pH is alkaline in nature. This is for intestinal juice, succus entericus. Succus entericus is alkaline in nature, contains mineral salts, contain mucus, contain water, and it is secreted around 1.5 liters per day. 1.5 to 2 liters exact numbers we will not ask you in the exam because they may change from book to book. So that's why you should remember the concept, not the numbers. And secretion will increase after meal. After you take the food, then secretion of succus entericus or the intestinal juice will start. As I already described, where the enzymes are present for digestion of carbohydrate and protein. Digestion of carbohydrate and protein is done through the enzymes present on the brush border rather than within the lumen or within the succus entericus. Suppose this is a small intestine and it is thrown into folds. And this is the lumen. In the lumen, you will not find enzymes for digesting carbohydrate or protein. You will find only pancreatic lipase. Pancreatic lipase, which is secreted from the pancreas. It is present in the lumen. So fat digestion will take place in the lumen, whereas carbohydrate and protein digestion will take place here at the brush border, at the brush border. Okay, what is the digestion? What digestion is taking place in the small intestine? In the small intestine, carbohydrate and are broken down into disaccharides with the help of disaccharidases. Enzymes are present on the brush border. They are known as disaccharidases. Maltase and sucrase, they are all called as disaccharidases. So these disaccharidases are digesting the carbohydrate, whereas protein digestion is taking place with the help of trypsin and chymotrypsin. Protein digestion is taking place trypsin and chymotrypsin, whereas fat digestion is within the lumen through the pancreatic lipase. So the on the brush border, you will find enterokinase first, which is activating the pancreatic proteolytic enzyme. Plus, you will have disaccharidases and aminopeptidases. Disaccharidases example is maltase, sucrase, and lactase, which will complete the digestion of carbohydrate, whereas protein digestion will lead to aminopeptidases are the enzymes which will hydrolyze the small peptides into amino acids, and they are completing the digestion. This is a summary of the slide in where protein digestion takes place, where carbohydrate digestion takes place, and where is the fat digestion takes place in the different parts of the small intestine, different parts of the GIT. This is whole GIT. Okay, so we have seen digestive process in the small intestine, and through there are enzymes. We have said that these enzymes are present for, let's say, digestion of lactose is through the by the enzyme lactase. If there is deficiency of lactase enzyme, the person will have problem in digesting the lactose of the milk, lactose which is present in the milk. So it is poorly digesting, and this undigested lactose, when it enters into the large intestine, lactose entering into the large intestine, sorry, this will be just like a substrate for the bacteria, for the organism there. So they will act on this undigested lactose, which will lead to formation of CO2 and methane gas. Formation of large quantity of CO2 and methane because of the lactose is coming as free lactose or undigested lactose in the large intestine, and it will be acted upon by the colonic bacteria. This will lead to generation of production of gas, CO2 and methane, which will lead to inflation or distension of the large intestine. This will lead to cramp, pain, abdominal pain. Pain will be felt by the person and followed by diarrhea, followed by Diarrhea. Diarrhea occurs why? Why diarrhea will occur? Due to lactose. What is the cause?
Osmotic pressure.
Exactly. Who said this? What's your name?
Sarah.
Sarah. Very good. Very nice answer. Because we have seen, because this is in the next lecture, large intestine, that there will be absorption of water. If there is something which is osmotically active particle present in the lumen, it will grab the water. So water will, instead of going into the circulation, it will come into the lumen, and this will lead to the diarrhea. So diarrhea because of the osmosis, or this is called as osmotic diarrhea. Osmotic diarrhea. Good. Small intestine, again, there will be for absorption of protein, carbohydrate, and vitamins indiscriminately. Indiscriminately absorption of all these things, meaning that if they are present in large quantity, suppose you have taken a very meal which is high in protein, so you will have many amino acid or peptides present in the lumen digestive, so they will all will be absorbed. If you have taken very sweet dishes, maybe in large quantity, then all sugar will be absorbed. This is the meaning that if it is present in large quantity, they will be absorbed large. If it is present in a very little quantity, then it will be absorbed in little quantity, depending upon the availability. But for calcium and iron, it it is not absorbed indiscriminately. It is not like if you have taken 3 or 4 tablets of calcium, you will absorb all the calciums. Let's say 500 milligram calcium tablets you have taken at a time, 4 or 5 tablets you have taken. Let's say 2 or 3 grams of calcium you have taken. So it will not absorb all the calciums. Why? It will decide based on the concentration of calcium in your blood or in your body. So if the calcium concentration is already high, it will not absorb. If the calcium concentration is low, it will absorb more. Similarly, iron is also. If the person is having normal iron content in the body, then if you give him food or a tablet or a medication which is high in iron, then this iron will not be absorbed. It will only be absorbed when there is a demand. So if the body is having, a body requires, if suppose person is suffering from anemia, and if you give them iron tablet or supplements which is containing iron, then iron absorption will be more because they are all regulated through hormones. So most of the absorption is occurring in the first two parts only, duodenum and jejunum, whereas rest of the parts is just like a reserve present for maybe an emergency situation, except for few elements like which are these. This is vitamin B12 and bile salts. Even though it is absorbed, everything is absorbed in the duodenum and in the jejunum, still vitamin B12 and bile salts will come till the terminal ileum, where it will be absorbed. So this is a specific site for absorption of the vitamin B12 and bile salts. If because of some reason, this terminal ileum is resected or cut or operated, that time the person may suffer from vitamin B12 deficiency, or person will suffer from bile salt deficiency, because bile salts, there you have seen in the lecture of hepatobiliary system that there is an enterohepatic circulation. Bile salt should be absorbed from the terminal ileum to be utilized for future use. Only 5% is lost in the feces, whereas 95% will be reabsorbed. So any difficulty up till now?
Everything's clear, sir.
Any specific point you want to repeat from this lecture?
Doctor, we should memorize the table above.
Table? This,
Yeah.
this table,
Yes.
this table is a summary. Whatever we are describing in the slide from lecture 1 till the last lecture, all is summarized here in this table. So either you summarize this table perfectly, memorize this table perfectly, or you remember the things from the slides, one and the same thing, because the information which is described in the slide, it is summarized here in the tabular form. Okay, what is the next topic which you would like to hear from me?
The second one, doctor, please. But the absorption.
Second of small intestine.
Yes, please.
Okay. Let's stop here and then restart for the second one. Stop presenting. Then start sharing. I have to open the second slide first. Lecture 8. Okay, this is lecture 8, where it describes how the things are absorbed in the small intestine. How the things are absorbed in the small intestine. Here you have to remember basically the concepts which you learned it in which lecture? Lecture of physiology in foundation block. Active and passive transport mechanism. So I will go directly to that site. So 50% of the small intestine can be removed without any problem of absorption, except for the terminal ileum. It has to be remain intact because vitamin B12 and folic acid, bile salts are absorbed at this area only. So the small intestine terminal ileum has to be spared even if there is a problem, or maybe the other part can be easily removed if there is a problem. The absorption is more in small intestine because of the larger surface area. Larger surface area we have seen the surface area is more because of the folding. There are folding of the mucus. There is a villi and there are microvilli. So this increases the surface area quite a large time. So intestinal absorption could be active or passive. When we say active absorption, that means it requires energy. When we say passive absorption, that means there is no utilization of energy. When we say primary active transport, that means energy is spared at the same site. When we say secondary active transport, we say the energy is utilized somewhere else and the absorption is occurring at this place. So this is the meaning of primary and secondary active transport. The epithelial cells are lining next to each other. I will draw it on maybe I will share with the whiteboard. Is there any option of whiteboard sharing? Yeah, Microsoft Whiteboard. Okay. Why so many things are starting? So let us say we have put I will draw it vertically. This is the lumen, and these are the epithelial cells. Same thing on the other side. This is a, you can say, the longitudinal section of the small intestine. These are the epithelial cells. These are the epithelial cells. So in the lumen, you will have so many things. Let's say you have glucose, you have sodium, you have water, mucus, everything. So the, the beauty is that they cannot pass from these areas adjacent. These things cannot enter into the, and here you will find the blood vessels. In the villi, you will have adjacent blood vessels. Whenever they are absorbed, they have to enter into the blood vessels, capillaries or arterioles. So they have to enter. They cannot go through these areas in intercellular space, intracellular, you can say, in between the two cells. They cannot go because these are the tight junctions. Can you see my whiteboard? Are you able
Yes.
to see? Okay. So the things are not able to enter into the interstitial space and into the blood through these areas. These are called as the tight junctions. They don't allow. So from where the glucose or sodium or water or anything will enter, it will enter through the cell membrane, mucosal membrane. From here to here, they will enter into the cell. Then they will leave the cell, enter into the interstitium. This is an interstitium area, interstitial space, and from here it will enter into the blood vessels. So there are three steps. Step number one, from the lumen into the cell. Step number two, from the cell into the interstitial space. And from the step number three is from interstitial space into the blood vessels. This is the sequence. Now let us go back to the slide. How to go back to the slide? We have to minimize or close. Share this whiteboard. No. Well, let us go to the slide now. Again, coming back to the slide. Oh, it started again. Sorry, there was option for resuming. So tight junctions are there. That's why they don't allow. Only thing is that it has to go through the surface with some carrier protein. Anything has to be absorbed. It has to be through some carrier protein. OK. So here it is described as the structure of a villus, where in the center of the villus, you will find blood vessels. Suppose this is the villus, and this finger is nothing but the blood vessels. So blood vessel is in between the villi. In between the villi, I will show you the picture. And also not only the villi, not only the blood vessel, but there is a lymphatic vessels are also there. There is a capillary network as well as the lymphatic vessels, because lymphatics are required for absorption of the fat molecules. Okay, coming to the crypts of Libercone. I will show you in the picture, that is more easier than. Okay, this is the structure of a villus. The villus consists of, the core consists of the blood vessel, capillary network, as well as the lacteal here. Can you see it here in the center? In the center, these are the blood vessels and lacteal, whereas the bottom of the villus, this area is called as the crypt of Libercone. Crypt is nothing but a wadi. Crypt is nothing but a wadi, and these are the, suppose these are the two mountains. If you go here to here, there will be. So this trough or the crypt is the area where the new cells are forming. New cells, new mucosal cells are forming, and they will be moving up, 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 and within 3 days, they will reach up to here and they will be getting shed off. So within approximately 3 days, the whole mucosa is replaced by the new cells. And what is the structure of a cell? Cell is look like this, with having fibers or microvilli at the top edge. These are called as the microvilli, which is forming the brush border. Okay, coming to the absorption of sodium and water. I will show it directly in the picture so that I don't have to draw. So these are the brush border, and on the brush border you will find some carrier protein. Carrier proteins are there, which is responsible for carrying in and out the glucose, galactose, fructose, as well as sodium. So there are different types of carrier proteins are there. So let us go back to this to the previous slide. Carbohydrate absorption. Carbohydrate absorption will be in the form of absorption of glucose, fructose. So they are occurring through a transporter which is known as sodium glucose transporter, SGLT. Sodium glucose transporter, which is nothing but a symport carrier protein. Symport. Symport means the one which will carry both sodium as well as sodium and glucose in one direction from outside to inside together. This is called as symport transport. Whereas counter transport means one will go in, another will go out. This is called as counter transport. This is called as secondary active transport. This is called as secondary active transport because why not primary? Because the energy is not utilized at this place. Energy is not utilized at this place. So sodium will bind to one site of the SGLT. Glucose or galactose will bind to the other side of the SGLT protein, and both will move inside. Both will move inside the cell. Then once they will be inside, sodium will be removed and glucose or galactose will be removed from here. Sodium will be thrown out of the cell through another channel, which is known as sodium potassium ATPase channel, which is present at the basolateral membrane. Here, the basolateral membrane, sodium potassium ATPase channel is there, which is removing the sodium out of the cell and taking 2 potassium into the cell. Similarly, the glucose and galactose which are there inside the cell now, in the second step, they will go to the interstitium through a channel which is called as GLUT, glucose transporter 2. Here there is no sodium, so that's why it is called as only glucose transporter. It will remove the glucose or galactose from here into the interstitial space, and then from here it will go into the blood vessel. It will be absorbed into the blood vessel again through the GLUT transporter. Again through the GLUT transporter. Yes, they are.
So, doctor, the only transporter require energy, the sodium and potassium transporter, right?
Yes, this is why
The
it is
other does
called
not
as,
require.
it is why it's called as primary. And because of this pump, sodium is moving in. Why? Because whenever something has to be moved, there should be difference. If it is one thing is on one side higher, it will move to the lower side. So in the lumen, sodium is high, and within the cell, it has to be kept low, then only it will move inside. And why it is low inside? Because sodium potassium pump is throwing all the time 3 sodium out in replacement with 2 potassium. So 3 sodium ions are going out and 2 potassium are coming. That's why sodium is low inside the cell. If there is low sodium, this will easily move sodium from outside to inside through the channel. This is the reason. So in this way,
transporter does not require anything.
yeah, here they don't require any energy. Here they only require that the 2 seats should be occupied. 1 seat for sodium, 1 seat for glucose. Then only they will move inside. If it only one particle is attached, they will not move. If it is only sodium attached, nothing will happen. If only glucose is attached, nothing will happen. When both will sit here, attach here, then only they will move inside. So they are both together moving inside. That's why it is called as symport or co-transport, you simply say, together. Whereas if opposite, I will show you it in the next slide. So this is how glucose is absorbed and sodium is absorbed. OK. How proteins are absorbed? Proteins are also absorbed by secondary active transport or by tertiary active transport. Secondary or tertiary active transport. So amino acids are absorbed and small peptides are also absorbed. How these amino acids are selectively there are different channels, importers are there, different channels are there for a special type of amino acids. So one group of amino acid will use one type of transporter. Whereas small peptides are transported by third method that is called as tertiary active transport. Tertiary active transport. Because here it will happen in the third step. That's why it is called as tertiary active. I will show you in this picture, in this diagram. So first is the primary active transport. At the basolateral membrane, sodium potassium pump is there, which is throwing the sodium out. Because of this throwing sodium out, less sodium is here. And because of this less sodium, it will try to move from lumen to the into the mucosal cell. Along with sodium, amino acid will also join because this is sodium amino acid pump and it will easily move into the cell. From the cell, sodium will move out and the amino acid will move out of the cell through the amino acid transporter, which is present at the basal level, and then it will be absorbed into the blood. This is for amino acid. What about small peptides? Small peptides require another way. First, there should be primary active transport at the basolateral membrane. Then because of the sodium is less inside, there is another pump which is called as sodium hydrogen counter transport. Sodium will attach, hydrogen will attach, and hydrogen will attach on the opposite side. So sodium is moving into the cell and hydrogen is moving outside the cell. So hydrogen will be more here. Then there is another third pump, which is called as hydrogen small peptides pump. And by this way, hydrogen and small peptides both will be entering into the cell. And then after that, small peptides will leave the cell through the same channel, which is used for amino acid. So small peptides require third stage. That's why it is called as tertiary active transport. Whereas amino acids require only the second step. So that's why it is called as the secondary active transport. Are you getting my point? Understanding?
So you mean, Doctor, the hydrogen will move out from the cell and the small peptide will take hydrogen
Yes.
back?
Yes. Because see here, at the same time, there is sodium hydrogen pump. So the hydrogen which is moved into the cell again thrown back. So it is recycling, going in and out, in and out. And by this way, the two pumps are functioning.
Without requiring anything else, right?
Yes, energy
as
is
the
not
slide before.
required. No energy is here. At these three places, no energy. Whereas energy is mainly used at the basolateral membrane. So that's why all of them are secondary active, secondary and tertiary, and here it is the primary.
And the basolateral membrane, just only one transporter, which is the sodium potassium.
Yes, yes, yes.
The other is facilitated.
Yes, others are secondary or tertiary active because if you block this pump, let's say you block by some chemical or something, if you block, nothing will happen here. So this is the main pump. If you block sodium potassium pump, the cell will not function. Cell will die. Usually the death happens because of the closure or stoppage of the sodium potassium pump. Fat absorption. How the fat absorption? What it will require a special type of protein. Which protein is it require for absorption of the fat? As you have seen in the previous slide, glucose requires glucose sodium transporter SGLT. You saw sodium and protein amino acid transporter. For fat, which transporter is required? What is the transporter for fat?
Does not require any transporter.
Why?
Freely,
Why?
because it's lipid soluble, can enter the cell.
Okay, good. Our cells are made up of a membrane. We call it as lipid bilayer. It is formed by the lipid. And you want to transport the lipid. So lipid can easily transport through the, it will just stick to the wall and will be moving into the cell. So it does not require any special type of transporters. So, but here the fat absorption, it is in the lumen of the small intestine. It is present in the form of what? Micelles. It is present in the form of smaller particles which contain hydrophilic and hydrophobic end. Hydrophobic end contain the fat as well as the bile salts, whereas the hydrophilic end is outside. So that's why it is kept in a liquid state. So here are the steps. In the form of monoglyceride and fatty acid, they will combine with the bile salts to form the micelles. These micelles will reach to the membrane. When they reach to the membrane, they will be easily change their shape into two parts, that is the bile salts as well as the monoglyceride separated, and they will move into the cell because they don't require any protein. Once they are inside, again they will together by the fatty acids and the monoglyceride, they will combine to form the triglyceride into the cell, and these triglycerides will be enveloped, or you can say wrapped into a lipoprotein coat, which will lead to formation of chylomicrons, and these chylomicrons will be moving out of the cell through exocytosis. These are becoming big particle, so they will come and bind with the cell wall, and the cell wall will open it from the other side and they will go out. This is called as the exocytosis. And after that, they will enter into the lacteal, that is the lymphatic vesicle. They will be entering into the lymphatic vesicle. This is how the fats will be absorbed. Okay, formation, iron absorption. Sorry. Iron will be absorbed in the form of ferrous iron, heme iron and ferrous iron. Through again energy dependent carriers. Again, they require some carrier protein by different energy dependent carrier for heme as well as ferrous iron. Why iron is required? Iron is required in our body to form hemoglobin, which is required for formation of the RBCs. So for RBC production, we require continuous supply of iron. It is into the body by the iron transporter called as ferroportin. Whenever iron is present, it will go through some channels. So these channels are called as ferroportin. I will show you in the picture. And also the absorption of the iron is controlled by a hormone called as hepcidin. If you remember the lecture of liver and biliary system, I told you that liver has got some synthetic functions. It will synthesize something, produce something. One of them is the hepcidin. Hepcidin is a polypeptide and it is required for regulation of the iron in the body, iron regulator. Hepcidin is a iron regulator and it will inhibit the iron absorption. Inhibit the iron absorption, or you can say iron transport, you can say. So it will inhibit iron transport. Hepcidin is not facilitating. If hepcidin levels are high, iron level will be low. If iron level will be, or if hepcidin level is low, iron can be easily absorbed. So one of the investigation for uh, non-responding anemia is to check for hepcidin levels. Check for hepcidin levels. Maybe it is high. So I will show you the things from the picture only. So iron, dietary iron, which may be produced in the form of which may be in the form of heme iron or the ferrous iron. This will be transported into the cell by a protein called as heme carrier protein or divalent metal transporter 1. Once it is inside the cell, again they will combine and remain as a store. This storage form of iron is known as ferritin. It will be converted into ferritin. So storage form of iron is ferritin. If it is not required, suppose no one asks for the iron availability, then within 3 days, along with the epithelial cells, it will be shed off and it will be lost from the body. Suppose iron is required, then it will be moved out of the epithelial cells into the interstitium and then into the blood through a protein called as ferroportin, through a channel which is called as ferroportin. So ferroportin is the one which is transporter protein. Ferroportin is nothing but a transporter protein, channel protein, you can say. Whereas within the blood, iron again cannot move alone. It has to be bound with a plasma protein which is called as transferrin. So transferrin is a plasma protein which will bind with the iron, and then in the bound form iron can move from one area to other area and it will reach to the bone marrow. So hepcidin is released from liver and it is controlling this ferroportin. Ferroportin is acted upon by our action of hepcidin is on the ferroportin to stop them and it will be lost from the body. Calcium and
Doctor,
vitamin. Yes.
should we memorize the transporters, divalent metal, and the heme carrier?
No. Just remember hepcidin. Just remember the transferrin and ferritin and ferroportin. Calcium and vitamin absorption. Calcium and vitamin absorption again through the channels, and vitamin D is in increasing the absorption of calcium. So you will find that every time you buy a drug which is calcium, you will find that calcium plus vitamin D3 is there because it will help in the absorption of the absorption of the calcium. Water soluble vitamins are easily absorbed because they don't require any protein or they require protein, but they don't require the mechanism like secondary active or primary active. They can be easily passively absorbed. Passively means from very high concentration outside the cell, less concentration inside the cell, it can easily go inside the cell. You have to remember that vitamin B12 is absorbed along with intrinsic factor, which is released from the intrinsic factor is released from stomach, and it is absorbed in the terminal ileum. It is absorbed in terminal ileum, and the process is endocytosis. Endocytosis means, what is the meaning of endocytosis? Suppose this is the epithelial cells and the vitamin B12 is outside, so it will stick to this area and this area will go inside, and a time will come when it will be within the cell. It will be broken into the cell. This is called as endocytosis. So all these nutrients which are absorbed, they will be taken through the blood. These are combining to form the portal vessels, and these portal vessels will drain into the liver. Within the liver, they will remove the bacteria or debris, detoxification, and then it will be traveling through the hepatic vein into the systemic circulation. It will come into the system. So liver is a checkpoint for all these materials. This slide shows the how much amount of water is present in the small intestine. Amount of water present in the small intestine is about 9.5 liter. Approximately, it can be 10 liters, it can be slightly less, but let's say it is 9.5 liters. Out of that, 9 liters will be absorbed in the small intestine. So the numbers are not so important, but still it will give you idea that a very large quantity of water which is present, it is absorbed. It is not thrown out of the body, but it will be absorbed. Almost 99% of the water is absorbed. When out of that 5 liters, 500 ml will reach to the large intestine, out of that 350 again absorbed in the large intestine, and only 150 ml or gram will leave the body in the form of feces or through the feces. So this slide shows that even if through the feces per day, if the feces passage is increased, let's say from 2 times to, let's say 5 times in a day, 3 times extra, what will happen? There will be more loss of water. This will lead to dehydration. So dehydration is the most important complication of the diarrhea or loose motions, and you have to correct it. So diarrhea is nothing but passage of highly fluid fecal matter, highly fluid, very liquid fecal matter with increased frequency of defecation. Instead of going for 2 to 3 times, the person goes to the bathroom or for defecation maybe 4 or 5 times or more. This is called as diarrhea. If it is increasing more than the normal frequency, we call it as diarrhea. Frequency as well as content of water. So this is the most, the diarrhea is a very simple disease, but it can lead to dehydration, which may lead to shock and person may land into death. Causes could be excessive motility because of irritation of the bowel, or due to excessive loss through the osmotically active particle. As just now we have discussed that lactose, which is undigested because of the lactase deficiency, this lactose, undigested lactose can lead to osmosis and diarrhea. It can be through toxins also released by the some of the bacterium, like example is Vibrio cholerae. Even viruses also can lead to diarrhea. One disease related to the absorption is called as celiac disease or gluten enteropathy. Gluten. Gluten is a protein present in our grains, cereals. It is part of the cereals. If the person's body becomes sensitive to this gluten, then it will start to react with it and will lead to malabsorption, destruction of the areas, destruction of uh, the cells there, and lead to malabsorption. Person will suffer from malabsorption. So it's an immunological disease, hypersensitivity disorder. And there is activation of the T cell, damage of the villi, and you know that there should be many folds, and these folds are destroyed due to the immunological reaction. It will become flat. It may become, the surface will become flat. And if it is become flat, the surface area is less, so less absorption. So gluten or celiac disease, what is the treatment? You have to avoid the things which are made from wheat, barley, and rye. These are the 3 cereals which you have to avoid. So basically, This is a hypersensitivity disorder, and the treatment is you have to avoid eating the things which is made by wheat, barley, or rye. Even biscuits, even cake, even some bakery product will lead to severe diarrhea and cramps. So now I described you the two lectures. Tell me what should we, or after that, if you have any special question, special thing, any slide you did not understand, rather than going to describe everything. Which slide or which part should I share with you now? Anything you did not understand in these slides? Or anything you want me to describe? Yes. What is next?
Large intestine, please.
Okay. That means all the lectures I have to repeat. Tell me what you did not understand from large intestine specifically.
Mainly the movement, astral contraction and mass movement.
Okay. Okay. Large intestine starting now. So the anatomy of large intestine, you know, the parts. The primary function of large intestine is a drying segment and storing the feces, drying it out. Whatever the content reaches to the large intestine, it will absorb excess of water till it is removed from the body. So what is present in the large intestine? Large intestine contains the chyme, which is nothing but the feces, which is having undigested food, which is not possible for the human body to digest, as well as some of the unabsorbed bile salts, a biliary component, and very little amount of water. Out of that, again, 350 ml of water will be removed before the feces is going out of the body or thrown out of the body by defecation. So large intestine also discussed in motility, secretion, absorption, and digestion. Here, two types of movements occur in the large intestine. Haustral contraction, it is similar to the segmentation contraction, and mass movement, which is similar to migrating motility complex. But the main difference in mass movement and migrating motility complex is that migrating motility complex, or MMC, they are smaller waves, weaker waves, which is traveling from very short distance, few centimeters. It starts from one point and move with a very little distance and die out. Then second contraction will start here and then it will move. Here, opposite to that, in large intestine, there is a mass movement. There is a strong peristaltic wave, which is starting at one point and putting the contraction or throwing the content from one area till the rectum, This is a main difference in uh, large and small intestine. Haustral contractions are similar to the segmentation contraction. So they are also initiated by the autorhythmic cells present in the smooth muscles of the colon, which is helping in mixing the colonic content and also rolling the food, rolling the chyme to come in contact with all the parts of the mucosa so that it will be absorbed easily. Maximum absorption occurs. Haustral contraction, they are occurring very slowly, very slowly. If you remember the contraction, segmentation contraction, they are occurring around 12 times per minute in the duodenum and 9 times per minute in the jejunum. But here it is occurring one contraction every 30 minutes, one contraction at every 30 minutes. So it is very slow contraction and relaxation. But the thing is that it will be similar to the segmentation contraction. So it will divide the large intestine into various segments. But this segment will not change very frequently. It will change after half an hour. So after half an hour, there will be picture will be like this. So the position of the contraction will change, but it will be very slow. These opposite to that, mass movement or the strong peristaltic waves occur. They occur very strong and they occur 4 times or 4, or let's say 4 to 5, 2 to 4, 2 to 3 times a day, depending upon the type of meal or depending upon the frequency of meal the person eats. Suppose the person is eating 3 times a day, then there are chances that mass movements will occur 3 times a day. If the person is eating 4 times a day, the chances of occurring fast movements at a speed of 4 times a day. And what they will do, they will throw all their content from the large ascending colon, transverse colon, descending colon, the S-shaped sigmoid colon, and the rectum. So they will be moving the content of the large intestine very fast, and then they will bring it to the rectum. They will bring it to the rectum. Suppose this is the rectum. Let's say this is a rectum. If it is becoming full, this will lead to stretching. This will lead to stretching of the rectum. This stretching of the mechanical stimuli will carry the signal to the spinal cord at the level of S2, 3, 4, 2, 3, and 4 segment of the spinal cord. And from here, the outgoing signal will come and it will cause a relaxation of the rectum so that defecation occurs. This is called as defecation reflex. So whenever the food enter into the stomach, it will cause contraction of the colon. When the food is in the stomach, it will cause contraction of the colon and may starts the mass movement. This is called as gastrocolic reflex, starting in the stomach and causing effect on the colon. This is called as gastrocolic reflex. This gastrocolic reflex usually occur 3 to 4 times per day. 3 to 4 times per day. When you eat, you feel that as if there is a stretching of the rectum, which is nothing but due to some contractions. Not the same food is entering into the rectum. This is called a gastrocolic reflex. So large intestine, same like a small intestine, secretes some fluid, which is called as, which is nothing but the mucus plus the soda bicarb. Soda bicarb will keep the environment alkaline. Mucus will facilitate the movement of the feces outside from the large intestine into the rectum and from rectum to the outside. What digestion is taking place? Nothing is digested in the small intestine for the human being. It is the undigested thing which is received by the large intestine will be acted upon by colonic bacteria, and they will digest it for their use, not for the use of human body. For their use, they will be digesting and they are extracting some food from it. The function of the bacteria is to synthesize vitamin K also. It will also keep the immunity of the small intestine intact. It will also keep healthy small intestine. Contractions will be stronger if the bacteria are there. These are bacteria are not harmful bacteria. So main function of the large intestine is to store the feces till the proper time comes to evacuate it or defecate it. Another function is to absorb water. Another function is to absorb water. Then what remains is the feces. After absorption of water, feces will be formed and it will be eliminated from the body through the from the defecation reflex. These are the functions of the colonic bacteria. These bacteria will enhance the intestinal immunity. It is helping in motility of the large intestine. It will help in the integrity of the cells of the large intestine and also contribute to the absorption of calcium, magnesium. These are the functions of colonic bacteria. So defecation reflex is nothing but after the mass movement, when the chyme or the feces enter into the rectum, rectal wall will get stretched. This stretching will lead to signals going to the spinal cord. Which segment? Spinal cord between S2 to S4 segment. Sacral 4 to sacral 2 to 4 segment. And from there, the command will come to the external anal sphincter, which is nothing but the voluntary muscle, or skeletal muscle, and this will cause relaxation of the rectal muscle, causing defecation to occur. So I will show you the diagram. So here is the rectum, which is having two sphincters. One is internal anal sphincter, which is formed by the smooth muscle and it is controlled by the autonomic nervous system, whereas the external anal sphincter is nothing but the skeletal muscle and controlled by the skeletal nerve coming from the S2 to S4 segment. So normal defecation reflex starts with filling of the rectum due to mass movement, then reflex contraction of the rectum and relaxation of the internal anal sphincter. Up till here, the feces is not out. Feces will out only when there is voluntary relaxation of the sphincter. Voluntary relaxation of the sphincter leading to defecation. Some word about the constipation. Constipation is nothing but the feeling of defecation and there is no passage of stool. Feeling of defecation without actual passing of the stool usually occurs due to some psychological condition or where the person is not able to ignore the urge to defecate or low amount of diet or less amount of diet, and there may be spasm in the colon, or there may be injury to the nerve pathway, which is carrying the signal from the rectum towards the sacral spinal cord. So spinal cord injury or injury to the nerves can lead to constipation. Okay. Do you know? Do you need anything?
Very clear, Doctor.
Thank you very much, Doctor.
Thank you so much, Doctor.
Thank you, Doctor.
So I have for you some practice questions. Not practice question, rather case scenario. Let me project one slide. If you need it, I will explain, or maybe I will leave it for you to see it where it is case histories. So this is actual tutorial. The previous one was just the question answers, or the explanation or the lecture only. Here, a 42-year Saudi male presented to us with 2 years history of excessive hair fall. Huh? and flatulence, passage of gases. With recent worsening of the symptom, the hair fall becomes more, the passage of gases is become more. So he came for further investigation and management. There is additional history revealed that while examining, it was found that the person lost 10 kgs in last 2 years, 10 kgs, and occasional episodes of diarrhea. There is loss of weight and there is diarrhea also without blood and mucus. He was diagnosed as having IBS. What is IBS? Irritable bowel syndrome. IBS is mean irritable bowel syndrome. It becomes irritated and then it will pass the stool and manage accordingly. He was treated for IBS only. The clinical examination revealed thin person, pale looking and ill looking patient with eyes in sunken, maybe because of diarrhea. Scanty hair, hairs are lost, so you will find scanty hair with signs of angular stomatitis. Here at the angle of the mouth, you will find some inflammation. Stomatitis means inflammation of the mouth, oral cavity, and an unevenly spaced beard. Beard is having so many, not all the, it's not very good or hairs are not much in the beard, scanty hairs. When the doctor advised him the lab investigation, he was found to be anemic. Blood hemoglobin was low, 10 grams only, 10 grams per deciliter. His mean corpuscular cell volume or RBC was very thin, you can say tiny, 65 uh, cubic micron. Serum iron and TIB, total iron binding capacity and folate levels were also low. So he is a case of, what is the primary impression by looking at these things?
The anemic.
Yeah, anemic. He is suffering from anemia. Which type of anemia?
Iron deficiency.
Why iron deficiency?
Because the iron is low.
Where is iron low?
Oh, sorry, I read it wrong.
Yeah, iron is low. Serum iron as well as total iron binding capacity is low. Plus there is one more indication. It is microcytic cells. Cell size is tiny. Microcytic. Microcytic hypochromic means iron deficiency. OK. So he has also abdominal symptom, right? He has got diarrhea, irritable bowel syndrome was diagnosis before. So he has got some abdominal symptoms. So doctor advised him endoscopy. What is endoscopy? What is the endoscopy means? Endoscopy means visualization of the lumen, intestinal lumen with the help of instrument called as endoscope. So we are putting a pipe inside going through the mouth and reaching to the upper GI tract up till stomach and maybe up to the duodenum. It was found that showed loss of Kirking, Kirkring's folds in descending duodenum. What is Kirkring's fold? What are these? Who discovered this fold? I think you are just putting the themes on recording and then you are not answering. Are you with me? Hello.
Yes,
Yes,
doctor.
yes.
Yes, doctor, we are with you.
Okay. I thought I am just recording your lecture and then you will listen it afterward. What Kerkring's folds are? Have you seen? Have you come across this terminology?
Flaps in the small intestine.
Yes, in the lab in anatomy, you found that these are the folds in the mucosa of the small intestine, discovered by Dr. Theodore Kerkring. He's a anatomist maybe, and it is also known as plicae circularis. Plicae circularis or Kerkring's fold is the same thing. Also, histopathology section was taken, and it is seen under the microscope, and it was found that there is all the villi are atrophied. The villi are the villi was up normally like this, very strong. Now they become like this. So there is atrophy of the villi. These are the villi. Now they become like this. So atrophy of the villi is formed, villus atrophy. Serological tests were done, which was found to be positive for anti-gliadin and anti-reticulin and anti-endomysial antibodies. Oh, what is these? What are these immunological things? These are the antibodies. So what may be the diagnosis?
Autoimmune disease.
Yes, autoimmune disease. Here it is written. Celiac disease was strongly suspected. Celiac disease was strongly suspected. So this is a case of autoimmune disease, gluten enteropathy, gluten enteropathy. He is sensitive to gluten, and that's why he suffer from atrophy of the villi because of the loss of villi due to antigen antibody reaction there. What should be advised to this patient if he is sensitive to gluten?
Gluten-free diet.
Gluten-free diet, very simple answer. In the market, we have many gluten-free diet, even biscuits, even samoli, even pasta, even the what you call shofan. What is shofan? So all these
Oats.
are,
Oats.
yeah, oats. Oats also should be gluten-free. Gluten-free should be there so that the person should not become reactive to that, and he can absorb the things properly. So for celiac disease, the usual features are abdominal pain and distension because of the production of undigested material, and this will lead to action of bacteria, and this will lead to formation of gases and distension, and will followed by diarrhea. Bloody stool may be there, chronic diarrhea or constipation may be there, flatulence may be there, and greasy, foul-smelling stool will be there. Greasy, foul-smelling. It could lead to vomiting also. Why greasy stools? Because of absorption of fat. If absorption of fat is not there, the stools will become having oil in it, and they when defecation occurs, they will be found floating in the pan, floating in the pan. Other signs and symptoms may include, because of absorption is decreased, the person may suffer from anemia or some deficiency of any other element. There may be easy bruisability or bleeding, bone joint pain may be there, defect in the dental enamel, fatigue, weakness, mouth ulcers because of the decreased absorption of the vitamins, loss of weight. Many things are not absorbed. So this is a malabsorption is happening, and it can lead to in adults infertility and osteoporosis also. Person may come to you or to the clinic with not able to conceive, or anemia. Person may come as more commonly anemia, diarrhea, chronic diarrhea, or unable to conceive. In children, celiac disease test may be ordered when the child exhibits some digestive tract symptoms or delayed development or short stature, or when he is not able to live. Failure to thrive means those children which are having excessive loss of weight and they are about to die or not able to cope up with the life. Then we have to think about there is absorption problem. So here is the mechanism of celiac disease. Wheat and wheat products contain gliadin and gluten, and these are the protein antigen. When they come and act in the body, they will be forming antibody formation, and these antibodies are nothing but anti-gliadin antibodies, anti-endomyosial antibodies, and anti-tissue antibodies, anti-tissue transglutaminase, which will appear in the upper part of the gastric mucosa or also in the serum. This will lead to malabsorption symptoms. The reaction is there and it will lead to malabsorption and loss of mucosa. Same thing which is shown here. What will happen? Villi will be atrophied. There is a crypt hyperplasia. Crypts will become more because of more cells will be forming. Decreased goblet cells, increased interepithelial lymphocytes and immune cells in the lamina propria and cytoplasm vacuoles will be there. This is histological histopathology. So another case, another type of this case study. 29-year-old woman with recurrent vomiting, diarrhea, abdominal pain with muscle weakness and fatigue for past 6 months. So since last 6 months, she's suffering from diarrhea, chronic diarrhea, abdominal pain, and muscle weakness. She described early satiety and bloating. Whenever she eat, there will be less amount of food she can eat, and bloating sensation means full or gases or something like in the stomach. Postprandially, after the meal, she had recently lost 30 pounds. She lost around 30 pounds of the weight. She complained of numbness and tingling in her fingers, which are radiating up to the shoulders and also the feet and hips, but was more marked distally in the distal parts of the body. She stated that her foot drop condition had worsened. There is a history of foot drop and it become worsened now. She was experiencing increased muscle wasting, especially in the palmar aspect of her hand. So diarrhea, abdominal pain, weight loss, and malnutrition in the adult woman. This is the blood picture. Quickly, we will finish and may not go in detail. So what this picture shows? Can you summarize the findings, positive finding in this picture? You will see slight increase in the WBC count. RBC count is okay, normal range. Hemoglobin is less. Hematocrit is also less. MCV is normal. Differential leukocyte count is normal. Let's go to the next slide. Here, serological test will show anti-IgA endomysial antibodies are positive. Anti-reticulin are also positive, and transglutaminase is also having a significant value. IgG antibodies are more. Biopsy of this patient from the small intestine presented what it shows. Villi are lost. You cannot see villi going up and down. So there is loss of villus and there will be infiltration with the lymphocyte. You will see infiltration with the lymphocytes. So again, this is a case of similar to the celiac disease. The last one. Sally is turning 30 years of age in few weeks. She has enjoyed variety of milk and dairy products in her diet ever since she was a toddler. So she used to drink and enjoy food, milk and milk product. Now currently she is 30-year-old. Recently she began to notice that she is experiencing period of nausea and pain within a few hours after drinking milk. Whenever she takes milk now, she is feeling nausea and pain. And after eating the foods made up from the milk. So basically milk is causing some problem. What could be the possibility? When person is not able to, yeah. What could be the
maybe lactose intolerance, doctor.
Which one?
Lactose intolerance.
Lactose, because milk contain large amount of lactose and she is having some problem after drinking milk. So maybe it is a lactose intolerance. Sally is suffering from bloating, cramps, lot of rectal gases and even diarrhea. So diarrhea plus bloating and cramp, pain. Most likely diagnosis is lactose intolerance. She developed maybe, what she developed? Maybe reaction to the lactose. What ingredients of the food beverages label should Sally look for if she is suffering from this type of symptom? What type of labels she should look for food products? Anything lactose free. She has to follow the lactose free diet because this is due to how this disease is diagnosed. You have to take a hydrogen breath test and lactose tolerance test. What is hydrogen breath test? The person fast overnight. He or she will be fasting for 12 hours. Then take a lactose solution. Then take lactose solution in the morning, and then physician will measure the levels of hydrogen in the exhaled air. She is fasting or she has to fast and then she have to drink lactose drink, and then the doctor will measure the hydrogen in the exhaled air, that is through the breath. High levels of hydrogen will be indicative of lactose intolerance. High levels of hydrogen will be indicative of lactose intolerance. Then there is a lactose tolerance test also. The person will consume lactose solution and the physician will take blood samples to measure the glucose levels, because lactose will be converted into glucose and galactose, right? If the blood glucose level remain the same, the body has not broken down the lactose properly. So if the blood glucose levels are not increasing, that means there is a problem of lactase deficiency. Lactase deficiency. Stool sample also can be taken. Here in the stool sample, lactose tolerance test and hydrogen breath test are not suitable for infants. This is for the infants. So physicians may perform a stool test. High levels of acetate and fatty acids in the stool can be diagnostic of lactose intolerance. This is the case. Again, one more case is there. So with this one, we come to an end of our tutorial. If you have any doubt, any query still, you can ask me.
Doctor, the first two cases is celiac disease?
Yes.
Okay.
So you may need this slide, right? Do you need this slide of the tutorial? I will put it on the Moodle. Thank you very much.
Okay, thank you, doctor.
Thank you. So we have to stop the recording.